Hello and welcome to the World of Optometry webinar. You are all very welcome from wherever you're joining us today. My name is Ihiana Chinedu Samuel and I'll be hosting and moderating today's webinar. I am joined by Rula who will be assisting me in today's presentation. But before we get started off, it is very important that we note some general housekeeping. Please, all participants should have their cameras turned off and also their mics off. This is so to eliminate any background noise which can cause feedback and noise disturbance to the speaker and other attendees. Also, it is very important to rename your electronic device with a name that you registered with and also the name that you would want to have on your certificate of attendance. If your name on the device does not match the name you registered for the webinar with, you might not get your accreditation. For the question and answer section, please post your questions into the chat box feature. And you can do this at any time during the presentation and they'll be answered at the end by the guest speaker. And for the questions to be answered, please address the questions to everybody. Rona, who will be the second moderator, will be able to assist you with any technical difficulties that you're experiencing or any issues as regards with sound and picture. Please, for her to be able to do so, let us know in the question chat box. She may also contact you to rename your electronic device during the presentation. If you have any queries about getting your certificate of attendance, she would also be able to help you in this process and get your queries resolved. To receive your certificate of attendance, you must remain on the webinar for a duration of 50 out of 60 minutes. Today's presentation will last between 35 to 45 minutes, which will be followed by a question and answer section. Now, I am delighted to present our guest speaker to you, who is Assistant Professor Saif Ullah, who is the professor for Pakistan Institute of Ophthalmology and also a doctor in Al Shifa Trust Eye Hospital, Rawalpindi, Pakistan. Please, Assistant Professor Saif Ullah, you have our attention.
Hello, everyone. Hello.
Yes, we can hear you.
Okay. So today's topic is optometric approach to ocular emergency. The objective of the topic is to know about the ophthalmic emergency and ophthalmic emergency kit, to know about the triaging of ophthalmic emergency, to know about the common ophthalmic emergency and their management in the due time for better prognosis, to know the detailed management of 4 common ophthalmic emergency: chemical injury, CRAO, acute glaucoma, and Hyphema. So the first term you should know the true ocular emergency. So what is the true ocular emergency? So a condition, or more specifically pain or some other discomfort that could have current or potential for visual loss in terms of functionality, or they have potential or in current state of structural damage, and which need immediate intervention and attention, that is termed as true ocular emergency. So the true ocular emergency, the history is a key differentiating between emergency versus urgency. So upon or in person, proper triage is essential. After our protocol, after the emergency has been handled, your office and your specialists' medical legal implications should also be kept in mind. So ocular emergency for all medical staff is very important, that if you save the patient eye as you save his life. So while taking history, vision is important, Is the vision is lost or blurred? Is it in one eye or in both eye? Visual field, is the visual field is sudden or gradual? Is the onset of diplopia is monocular or binocular? Is the onset of the pain, redness, and in its onset? And trauma history is also important. Contact lens wear, recent ocular diseases or surgery, other diseases, cardiac, vascular, or autoimmune, viruses, infections is have very importance in nowadays. Medication or recent changes to medications. So all these are important while taking history in ocular emergency condition. The emergency examination include visual acuity, visual field, pupillary examinations, ocular motility, external examination with any illumination and magnifying source, intraocular pressure checking, IOP, slit lamp examination, and fundus examination. It is utmost important that every clinicians should have their emergency kit, which is eye shield, pressure patch, sterile eye wash, agar brush, forceps, golf spud, pH pepper, and bandage contact lens. Medication Diamox, which is carbonic anhydrase inhibitor, and topical drops, antibiotics, NSAIDs, steroids, and cycloplegics. So this ocular emergency kit should be the part of every clinician. The eye shields, the pressure patch, and all dimensions in the slides. The true ophthalmic emergencies are urgencies. So the first approach to ocular emergency should be made on based on anatomical manifestation. So the ocular emergencies or urgencies can be taken from right from the eyelid till the visual pathway. So the common ophthalmic emergencies are the eyelid. Eyelid is an anatomical part which is the most anterior part of the eye. So eyelid laceration could be considered as an emergency. Orbital condition, retrobulbar hemorrhage, which can occur during cataract surgery, especially in peribulbar or retrobulbar injection. Orbital blowout fracture, which can be result from the blunt trauma. Orbital cellulitis, which can be result from infections. In cornea, the chemical burns or chemical injuries and microbial keratitis can also be classified as an ocular emergency. Going towards the anterior chamber, acute angle closure glaucoma is an ophthalmic emergency. While keeping in mind the globe, the eyeball, rupture the eyeball, or intraocular foreign body, which can be result from any trauma or any accidents. This can be classified as an ocular emergency. Retina. In retina, various conditions such as central retinal artery occlusion, central retinal vein occlusion, retinal tear, retinal detachment, and endophthalmitis can be classified as in emergency conditions. Proceeding toward the neurovisual pathway, giant cell arthritis, Horner syndrome, cavernous sinus thrombosis, third nerve palsy, and homonymous myopia, all these conditions are the most common presenting ocular emergencies to the ophthalmic clinics. So it is very important that the proper triaging of ocular emergencies and urgencies are done. So the triaging is the system of sorting the patient according to the urgency of their need. The triaging is come from the French term triad, meaning separate, shift, and select. So the mentioned condition in the previous slide, we should separate, shift, and select the proper condition for the proper interventions. The goal of the triage is to establish a level of urgency based on these common definitions. So the mnemonic I use is the simple way to memorize these emergencies. So the emergency which will be discussed in the upcoming slides is the emergency which need immediate response, which can last from 1 hour, or which can last from 1 to 2 hours. And the emergency condition which needs intervention and treatment within 24 hours. And the emergency and urgency condition that needs soon response up to weeks. And the elective procedures which need intervention and treatment within weeks to months. So the most common emergencies mentioned in the slides is that these sort of emergencies needs response within the or intervention within the minutes, which is chemical burns, orbital hemorrhage, and central retinal artery occlusions. Proceeding toward very urgent, within hour of the response is needed, that is endophthalmitis, cavernous sinus thrombosis, microbial keratitis, orbital cellulitis, intraocular foreign bodies, acute glaucoma, globe rupture, and RD width of macula. Proceeding toward the urgent emergencies, within which 1 day of the intervention is needed, which is orbital fractures, corneal abrasions, corneal foreign body, lid lacerations, sudden or recent loss of vision, hyphema, RD width of macula, and onset of diplopia. The two ocular, most common ocular emergencies is chemical burns, especially one thing which should keep in mind that the if the chemical injury is from alkali, it is very dangerous and it's need very immediate response. And the central retinal artery occlusions. Both these are very common ocular emergencies and which can be prevented with immediate intervention and treatment. Chemical injuries can be from acid and from alkali exposure. So acid penetrate through epithelium, carbonates, vinegars, and some refrigerators, while alkali exposure penetrate tissue more easily and have prolonged effect. Lime, plasters, cements, ammonia food in household cleaner, or fertilizer, and pesticide. Have patient bring agent if possible. So it's very important to investigate for the for the agent in your office uh, in a case presenting with the chemical injury. So treatment of chemical injury is copious irrigation with normal saline or with sterile water, tap water. Contact can be removed after irrigation. Sweep fornix repeatedly with a cotton swab. Examination of the irrigation and neutralization of pH. It is very important to examine the fornixes and the dorsal plates of the upper and lower lid. Debride the necrotic tissue where applicable. Neutralize the pH up to 7. Determine the area of involvement. Assessment by fluorescein staining. Assess the depth of the conjunctival penetrations. Vascular ischemia, necrosis of the limbal and bulbar conjunctiva. Loss of limbal vasculature plexus is a key indicator to the severity of permanent loss. Check the IOP with the tonopin after the copious irrigation for 30 minutes. So the classification of chemical injury is based on the Roper Hall classification. According to this clinical classification, there are four grades. In the grade first, the cornea will be clear. There will be no limbal ischemia, and the prognosis for this grade is good. In the second grade, the cornea is hazy, but the iris detail is visible. And in terms of limbal ischemia, it should be less than 1/3 of the cornea. And the visual prognosis in this case is also good. In the third grade, the cornea is opaque and the iris detail is obscured. The limbal ischemia is 1/3 to half of the limbal area, and the prognosis for this grade is guarded. In the grade 4, the whole cornea will be opaque and the iris detail wouldn't be visible, and half of the limbal ischemia will be present, and the prognosis for grade 4 is very poor. Treatment of chemical injuries. Acute all injuries, admit if severe. The case is severe. Topical antibiotic should be prescribed prophylactically to prevent the infection. Topical cycloplegia for the comfort and the assay, lower the assay activity. Topical lubricant 4 hourly, 6 times a day, and paraffin ointment at night is advisable. Oral analgesic and topical medication should be preservative free where possible. Acute severe injury, admit and consider the case. Topical steroid, prednisolone 0.5 to 1% initially, 4 to 8 times a day for less than 10 days. Topical ascorbic acid 10% is advisable every 2 hourly for less than 10 days. Oral ascorbic acid 1 gram 2 times a day is advisable. Systemic tetracycline and doxycycline is also given for better prognosis. So the ascorbic acid is essential for the collagen formation as in an effective scavenging for the damage of free radical. It should not be used in acid burns. Doxycycline is a drug of choice for chemical burn because it do not prevent only the tissue necrosis and facilitate healing, but also has very good anti-inflammatory effect. Paracentesis, in which the aqueous is drained to a needle from the acid, is also a choice to lower the IOP in cases of high IOP. And buffer phosphate solution is also advisable to normalize the pH in the acid. But this technique is very rarely practiced. Going toward the another common ocular emergency, which is central retinal artery occlusion. Central retinal artery occlusion causes complete hypoxia of the inner retina, acute coagulative necrosis followed by complete loss of nerve fiber layer, ganglion cell layer, and inner plexiform layer. The clinical features include sudden painless unilateral loss of vision or dimness of vision, usually CF or worse. White swollen retina with cherry red spot at the macula, arterial attenuation, cattle trucking, RAPD, visible ampullae in up to 25% of the cases. But remember that only 30% of the population, luckily, which have cilioretinal artery, have some good visual prognosis in the central retinal artery occlusion, because the papillomacular bundle is spare in case of the presence of cilioretinal artery, but it is present only in 30% of the population. The complication of central retinal artery occlusion include neovascularization, new vessels in 8%, and new vessel at a disc in 2% of the cases. The serious and devastating complication of the central retinal artery occlusion is rubeatic glaucoma, optic atrophy, ocular ischemia syndrome. Here is the two pictures. The one is the central retinal artery occlusion, in which the only sign is cherry red spot, the hallmark of this central retinal artery occlusion, and the whole retina is got ischemic. And in the second diagram, luckily, 30% of the population have uh, cilioretinal artery, which spares the macula in case of central retinal artery occlusion. And these sort of patients have good visual prognosis. Investigation is needed in cases of acute attacks. Uh, Priority should be met to rule out the cause. In case of giant cell arthritis that can threaten the contralateral eye, should be kept in mind. In late presentation, the clinical picture is less specific on fundoscopy of central retinal artery occlusion, which is the most challenging case. However, OCTs show the atrophy of the neurosensory retina. So the identification of causality is more important in the central retinal artery occlusion. Common causes are atherosclerosis, hypertension, diabetes, hypercholesterolemia, smoking, and particularly carotid artery diseases. Consider giant cell arthritis if the patient age is more than 30, and then go for the investigation like ESR, C-reactive protein, full blood count, temporal artery biopsy, anterior ischemic optic neuropathy. So, in short, a very multi-specialty opinion is required for the investigation, for investigating the causality of CRVO. But for eye care practitioner, it is very important in cases of the acute presentation of the cases that the GCA, giant cell arthritis, which is very devastating because the contralateral eye can be threatened. So the early intervention is needed to prevent the contralateral eye. Treatment and prognosis. Treat the affected eye if the presentation of the central retinal artery occlusion is within the 24 hours. If the IOP is raised, drop it with acetazolamide. Ocular massage is very important. Paracentesis can be done if the IOP is very high, more than 70 mm of Hg. Ophthalmic artery cauterization with thrombolysis is performed in some centers, but it is a very rare practice here. Protect other eye, treat the underlying giant cell arthritis with systemic steroids immediately. And the visual outcome in 94% of the cases are CF or worse at presentation. About 3% show some improvement with and without treatment. Neovascularization occur in up to 8%. However, disc neovascularization is uncommon. Proceeding toward the third most common ocular emergency condition presenting, says the acute angle closure glaucoma. So classical symptoms include unilateral presentation, painful eye, blurred vision, halos, nausea, vomiting. Characteristics include older patient, white, breast, hyperopic female, uh, older than 30 years of age. Peak age limit is 55 to 70 years. First degree relative with angle closure glaucoma should be inspected. Uh, History is very important. Previous history of episodes is very alarming and need early interventions. Medications and surgery history should be kept. So the picture show the unilateral case of angle closure glaucoma and see the left eye of the patient. In the second eye, the eye is inflamed. Both in the both picture, the eye is inflamed, and in the second picture, the pupil is mid-dilated, fixed mid-dilated pupil. Clinical features include acute angle closure attack, diffuse conjunctival hyperemia, cloudy oedematous cornea, fixed oval, mid-dilated pupil, visual acuity often significantly reduced. IOP ranges from 40 to 70 mm of Hg. Inflammation, aqueous cells and flares can be seen in the anterior chamber. Classic patient symptoms associated with acute angle closure glaucoma is very aching pain, redness, tearing, photophobia, blurred vision, halos, nausea, vomiting, and headache. It's very important that not all the patients with angle closure glaucoma have these mentioned symptoms. Proceeding towards the management of acute angle closure glaucoma, oral carbonic anhydrase inhibitor 250 to 500 mg Dimax is needed. Topical fixed combinations like Combigan, topical steroid uh, to, to reduce the inflammations. When the IUP is less than 45 mm of Hg, then add pilocarpine 1 to 2%. Definite treatment for angle closure glaucoma is laser peripheral iridotomy so that pupillary block can be eliminated. Uh, it's very important to go for the laser peripheral iridotomy of the for the fellow eye. Hyphema, uh, the most common condition usually after the traumas, blood in the anterior chamber. It has got a very multifactorial etiology. Trauma, surgery can be the cause. Spontaneously, it can occur in cases of neovascularization, fuchs-heterochromia iridis, and bleeding anomalies like leukemia, hemophilia, etc. Chemical finding and diagnosis. Layer of the blood or clot with suspended RBC in the AC called microhyphemia. If only suspended cells, damage to other structures may be seen. So the diagnosis is sickle preps, consider hemoglobin electrophoresis, rule of the rupture globe. Gonioscopy should not be performed. It's better to wait for 4 to 6 weeks in case of traumatic presentations. The treatment for hyphema is cycloplegics, topical steroids, control intraocular pressures. But remember that myotics should be avoided because it's increase the uveoscleral pressures. In the protective shield, elevate the head of the patient. Strict bed rest is needed. No aspirin containing product should be advised. Control the systemic BP. Anti-emetic drug should be prescribed. And when to go for the surgical intervention for hyphema. So indication for the surgical intervention of hyphema is that when the hyphema is large and persists for longer than 10 days, when the total hyphema persists for longer than 5 days, corneal blood staining, uncontrolled IOP, and add-wall hyphemas. Best to perform washout, AC washout, 4 to 7 days after the injury. Clot has time to solidify, reducing the rate of re-bleed. So it's better practice, and it's a safe practice to intervene on 4 to 7 days. But the very safe protocol in my own practice that if go for the surgical intervention after 7 days, so it's reduces the chances of rebleeding. The complication of hyphema is add ball hyphema, corneal blood staining, recurrent hemorrhage, secondary glaucoma, central retinal artery occlusions. And thank you very much. Any question?
Thank you very much for a very exciting and encouraging presentation. You have covered a very good topic and have given us some wonderful insights that we can take away today. We have some questions which have been submitted by our attendees, and with your permission, please, I would like to put these questions to you now. Can we go ahead, please?
Thank you, Samuel. So we will go to our first question. It says, are there any ocular emergencies where the patient pain is disproportionate to objective findings?
So yes, there are some ocular emergencies in which the patient pain is disproportionate to objective findings. As we mentioned in the very early slides, that for an emergency to be labeled as an ocular emergency, it's a need early intervention. So pain or any discomfort is the apparent features. But there are certain conditions, as I mentioned in the slides, central retinal artery occlusion, there will be no pain to the patient until and unless it proceeds toward the rubeosis, iritis, and increased IOP. And the next thing is that the pain threshold for the every patient is different. You know, when on in the clinical practice, you see a lot of patients that have a very obvious inflammatory signs, but they do not complain of the pain. So the pain threshold for the every patient and every subject varies.
Yes, thank you. There's another question. He says, like you mentioned, you use pilocarpine if pressure is less than 45. What the reason behind it?
Because in very high IOP, in case of very high IOP, the pilocarpine is not going to control the pressure, because the pilocarpine basically, if we go toward the physiology, so the 80% of the aqueous drainage occurs to the uveoscleral pathway, and the 20% is with corneal with uveoscleral pathway, and the 20% with the 80% with the trabecular pathway and 20% with the uveoscleral pathway. So if we check the mechanism of action of the pilocarpine, so it works on the uveoscleral pathway, which contribute to 20%. So when the pressure is above than 45 mm of Fg, so it's a very it's not respond with the pilocarpine, because that pathway contribute only 20% of the aqueous damage.
Okay. Another question, he's asking for chemical injuries patients. Which water is used for wash?
It's the ideal choice is normal saline.
Mm-hmm.
The normal saline is the ideal one. But if someone haven't normal saline, so it's better to go for the sterile water.
Yes. Okay. There's another question
The
from
normal
Laura.
saline,
Yes.
okay, the normal saline, if we check the pH and the properties of the normal saline, so it's very matching with the tear film and the tear. So the ideal
Okay.
choice is normal saline.
Great. So another question from Laura. She's asking, acanthamoeba or other contact lenses related issues are to be considered at what grade of severity?
Any microbial keratitis can be classified as an ocular emergency. But remember that it is the emergency which should be responses within the days that are comes in the means that at least in days the response is needed. So not only acanthamoebic, which is contact lens related ocular emergency, but every microbial keratitis should be considered as an ocular emergencies. Intensive treatment should be given. But
Okay.
as far as in my own practice, I deal only two cases with acanthamoeba. So the acanthamoeba cases are very resistant to the antibiotics, and chlorhexidine although it is not available here in our region, but we dilute it with normal saline, and chlorhexidine cases respond well. And acanthamoeba,
Yes.
it's very resistant. Acanthamoebic and fungal cases are very resistant, but chlorhexidine has got a very good response. Although in
Yeah.
that case,
Okay.
in that single case, our approach was to to not to prevent or reinstate the vision. In that specific case, because that was treated on many clinics, and most of the clinicians treat them with the Vegamox, the moxifloxacin, but that was not responding. And then we treat that case, I with my departmental head, we treat that case with the chlorhexidine by diluting it with the normal saline. And the OTN, we put that patient, and that we got very good response. And the purpose of that treatment was to just to save the anatomy, because that go to a very worse condition, and we got a very good response of chlorhexidine.
Right. Okay. Another question from Asad. He's asking, isn't topical steroids contraindication in angle closure glaucoma? As you mentioned it in treatment of ACG.
No, not really. It's not a contraindicated in angle closure glaucoma, because as far as in my own clinical practice, we have treated 10 cases of acute angle closure attack, and most of the case in it's a very it has got a very good response, because the eye is very inflamed, and you don't have only to decrease the IOP, but you should prescribe the steroid, and these are also mentioned in the Kanskis and American Academy of Optometry as well. The
Yes.
treatment for acute angle closure glaucoma, they give the steroid, but mild, better to go for the mild steroid. As better to go for the prednisolone or the fluoromethalone.
Yes. Okay.
It's the same practice. Better to avoid the dexamethasone and the betamethasone.
Okay. Another question, he's asking, can we give topical steroid in a case of traumatic hyphema associated with a large corneal abrasion?
Yes, because the steroids are the, if in very broad term, we can classify steroid as a life-saving drug. So steroid has got a very multiple advantages because when you are dealing in if the abrasion is not if the abrasion is very superficial, so there is the steroid is not going to harm the eye surface. So these are yes there should, but the safe protocol for all these is to go for the mild steroid.
Yes, right. Okay. We have our second question here. How to handle chemical splash into the eye immediately?
The first is copious irrigation
Yes.
with the any sort of sterile water. Better to go for the normal saline. The ideal one is a normal saline, but if someone don't have normal saline, so just sterile water is also going to neutralize. So the first and the foremost thing is irrigation with the water, with sterile water at least.
Okay.
And better to check the pH if the pH paper is there in the clinics. The guideline is that after the half hour of continuous irrigations, then check the pH. If the goal should be to keep the pH at 7.
Mm-hmm. Yes. It's a wonderful answer, actually. Okay, our third question. Does optometrist allow to remove a corneal foreign body, or the patient has to be referred to the ophthalmologist for removal?
No, it's a very difficult question, I would say. Basically, it's depend upon the country, the regulating body, and it's the question in our region, I would say. Still, there is no any optometrists are not allowed. They are allowed to remove the superficial foreign body, but the removal of foreign body and the scope of optometric practice vary across the world. So this is subject to the country or the country regulations, that how they regulate their optometrists and how much they define the scope of optometry in their healthcare system.
Yes. Okay. Actually, here we got several questions about how to get the presentation in PPT form. I guess they can email you to your email that is presented here,
Yes,
right?
sure. Yes, sure.
Yes. Actually, I would like to thank you very much for answering those questions. Unfortunately, in the interest of time, we may not have answered all the questions. Actually, if you do have any further questions you would like to be answered, you can email them directly with the email address, which is on the screen at the moment. And I'm sure they will be endeavored to get back to you as quickly as they can. Thank you. We'll get back to you, Samuel.
Indeed, this is a very interesting and engaging presentation. Thank you all for your attendance today. Your thoughts are very important to us, and we will be sending you an email for you to fill in and submit a short feedback survey to guide us in future presentation and topics. The next sort of optometry webinar will hold on 24th of April, and the topic will be complex lens fitting. We'll be glad to have you in the next section. For now, I will bring today's presentation to a close and wish you all a very good day ahead. Thank you for joining.
Thank you very much. Thank you.
Thank you all.